All right, folks, we're back. I'm your host, BKP. We're at Circuit World this morning. We'll be back at Sycamore Crossing next week. Come up and visit us in Blue Ridge. A little bit of rain maybe this afternoon, but it's going to be a beautiful weekend. The weather is great. Graduations tonight, tomorrow, a lot of them. This is big graduation, Memorial Day, Monday. Come up and spend some time with us. Dr. William Whaley, Dr. Raymond Tidman. Thank you, Northside Hospital. How are you today?
Good.
You have your jacket on.
All right, so obviously the jacket, this is my Vietnam jacket for Memorial Day. I mean, Memorial Day is not to celebrate the troops. It's not to celebrate the active duty. It's to memorialize the defeated, the dead, and remember the Poppy Day and
Right.
and all of that stuff. The second thing I want to say about this jacket is, I'm going to Ithaca, New York this afternoon. I was going this afternoon for my graduation of my grandson at Cornell. And last night about 9 o'clock, I get an email that my flight's canceled, and I am put on a 9 o'clock flight tonight because the airline of choice can't get enough pilots. And some of the pilots or flight attendants or mechanics or whatever it is that has to have a required number are out with the COVID. And so they're canceling 2% of their flights today, and the other airlines are canceling more flights. But the point I was making is, if people are looking for a good occupation, you got high school graduation today, right?
Yes, a lot of them tonight.
You got a lot of young men and women who don't really have any great idea what they're going to do. Let me recommend that you consider going to one of the aviation universities where you can come out with a degree and 1,500 hours, because the airline industry is bad trying to find pilots, and it's a pretty good lifestyle. If you're a clean living, moderately intelligent, and you want a good job, go to school, get yourself a degree. You have to have a degree, but go to one of those places that'll get you 1,500 hours while you're in college, and then they won't be canceling my flight, and that'll be 5 years from now. Okay. That was
I thought they canceled your flight because they couldn't figure out a good way to get to Ithaca.
That's right.
I didn't know you.
There is no good way.
Yeah,
there is no good way to get to Ithaca.
Yeah.
You have to fly to Syracuse and drive for an hour and a half.
Huh?
You have to fly to Syracuse and drive for an hour and a half.
Yeah, I know where
It's
Ithaca
tough.
is.
All right, you ready?
Yes, thank you, Northside Hospital Cancer Institute, Georgia Cancer Specialist. We appreciate it. Go ahead and start with.
All right. Well, when I sent this out to Ray, Ray's a bad knee-jerk guy. I got to tell you, Ray thinks deep about some things, but he's quick to come up with an opinion about other things. Now, I got to just tell you,
I can't do nothing.
I must have fired off on this one.
You did. I've sent this to Ray, and Ray sent me back a thing and said, a family practitioner who doesn't know how to treat atrial fibrillation should go to get another job.
Right.
Okay, this is not a family practitioner who doesn't know how to treat atrial fibrillation. This is actually a family practitioner who's sort of ahead of the curve and is trying to tell his patient what he thinks he ought to do, and the patient's arguing with him because he's been consulting.
So he brought in a second opinion. Okay, well, that's valid.
He's been consulting Dr. Google or his information. Now, we pay some attention to the time frame in here because the 7 years is sort of important. All right, I am confused, and my PCP says ask a hematologist. I'm a hematologist and oncologist. I have atrial fibrillation and have been on Coumadin for 7 years. Okay, so I have atrial fibrillation. I'm on an anticoagulant. When I started, the only anticoagulant available was Coumadin, so I took it for years. All right. I have high blood pressure well controlled. Type 2 diabetes controlled by diet, so that means he doesn't even have medicine. And gout. Well, gout you got easily to control as well. My PCP suggested a direct oral anticoagulant and prescribed Eliquis. Now, that's just one of 3 or 4 drugs that is of a different class and newer than rat poison. So let's go back to what he was taking before. Coumadin is rat poison. So when you buy these pellets at Home Depot and drop them in the hole for your rats, they eat them and then they bleed to death in there. So when they say Coumadin, that's rat poison. All right, he prescribed Eliquis. Now when you're taking taking this type of medication, the Coumadin, you have to have your finger stuck every 3 weeks, 4 weeks, or whatever, have your clotting measured, and then adjust your dose. So it's a constant monitoring. And it's not supposed to, it's like diabetes. You should have exactly the same diet every day in terms of how much celery, lettuce, and green stuff you've got that has vitamin K in it. So it does limit your activity some and your monitoring, correct? All right. I like to travel. Aha. I think he means travel farther than Eliquis when he talks about, I've been told years ago that I should worry about how to stop bleeding on the new drugs. Well, that's true. When these drugs first came out, with Coumadin, you can give plasma and immediately reverse the anticoagulation if you get shot, have a car wreck, or need surgery. The other drugs did not have a mechanism by which you could immediately reverse the anticoagulation. That was a negative factor. That is no longer true with the common drugs. So that thing is no longer true. I have a card that makes the cost of Eliquis reasonable. Now, that's a second reason that people that are on Medicare and don't have commercial insurance won't take the new drugs. They have a higher copay. Mm-hmm. And that can become an economic disincentive, but that's not an economic disincentive to this man. I have a card that makes the cost of Eliquis reasonable. Your suggestions, please. Well, I started thinking about this, and the first thing I want to do is just talk about atrial fibrillation, because I was watching television the other day, and I saw 4 ads for that little monitoring iPad thing, and then apparently these new watches, like Ray's always got a new watch, this iPhone watch, what they call it, what they call it?
They monitor your pulse.
They will tell you if you have atrial fibrillation. Okay, put up that first one there. So we're talking about atrial fibrillation. That diagnosis is made primarily by an EKG. That's what you're looking at there. Pull that down on him. So be suspicious of it when you're at your doctor and your doctor's doing a physical exam and he listens to you and you have irregular heartbeats. Then he's going to go and take an EKG. Now, I said I have atrial fibrillation. I'm going to show you just a minute how atrial fibrillation occurs and why so many marathoners, triathletes, and ex-endurance athletes have atrial fibrillation. Put up the next one there, Lonnie. Got it? Okay, this is 2 hearts.
Right.
There's a top part and a bottom part. On the left-hand side, what happens normally is the top side goes boom, blood goes into the bottom side, it goes boom and comes out the other side. So that's kind of like a spark plug bang in your car. Got it?
I get it.
Now, pull that down, Lonnie, because don't people focus too much on it. Now, when you run marathons, or you are a triathlete, or a big-time endurance athlete, you drop your heart rate because your ability to pump blood at maximum exertion has to go up. So your stroke volume goes up, so you can pump more liters of blood than the average guy. That means that your atrium of the heart gets bigger, the ventricle of the heart gets bigger, and once that atrium gets bigger, it does what's called remodeling in a fairly high proportion of people, and it sort of stretches out to the point that the electronic network within there is stretched, and then that top part, instead of going fire, just starts wiggling like that. So let's go to the next one, Lonnie. When it goes wiggle like that, people have a whole bunch of symptoms. They can have lightheadedness, they can have fatigue, they can have shortness of breath, they can just feel puny, or they can say, I can feel my heart going flip, flip, flip. Most people with atrial fibrillation, their symptoms are not awareness of flip, flip, flip.
They're completely unaware.
They are unaware. It is fatigue, it is shortness of breath, or it is, pull it down, Lonnie. It is the general, I just don't feel right.
And they have normalized that. This is me. I mean, most of the patients I come in, the majority come in with no symptoms. And I find atrial fib as a physical finding on exam. They've had no complaint.
That's exactly
They're
what
just
I
living
said.
with it.
Yeah, and, well,
Yeah.
When you say
right.
living with it, but what are they living with? What
They
has
have a
changed?
quivering top of their heart
Right.
they're not aware of.
But they just feel tired now all
They
of a
may
sudden?
or may
They
not feel
don't
tired.
know
They
it.
they may have just said, well, this is my life now.
Okay.
They don't they're older, right?
Right.
They just say, yeah, this is part of getting older. They don't have
Okay.
it. You can't compare yourself. Now, if you suddenly have a change, or
Yeah.
you're out on a golf course or cutting the grass and you have a sudden dizziness and you get lightheaded, then that's a real symptom. But if this becomes gradual, it's exactly like Ray says, you don't even know you have it. So go to the next one here. You got to have the issue is, see, is that the one that says stroke on it? All right. I gave you all those symptoms, shortness of breath, weakness, and everything else. Those are all rate-related and pump-related. But here the biggest problem with this disease is it is the most common cause of non-atherosclerotic stroke, meaning not a tight artery in your neck or your head. So you like these pictures, don't you? Mm-hmm. So when this heart starts flicking like that, the blood doesn't flow through it particularly well, and it can make clots in that part of the heart that's not beating correctly. And then that clot breaks off, goes down in here, and goes to the head, and you got a stroke. Okay, pull that down, Lonnie. So, when you're talking about, put up the next one. When you're talking about atrial fibrillation treatment, if the guy's got rapid heartbeat and complaining his heart goes 180 beats a minute and he ends up in the ER, then you have to treat this to control the rate. Secondly, you've got the idea that you've got to control, in addition to rates, you've got to control, you may have to deal with blood pressure fluctuations and so forth. So there's lots of things that you do in the treatment of atrial fibrillation that are unrelated to stroke. This question that this guy has is purely related to stroke prevention. And you would get the sense from you can pull that down, Lonnie. You got the sense from the fact that he wants to travel internationally, that he doesn't have any other major conditions, that he's not having rate control issues, and he's not having issues with his stamina. Now, we got to have an algorithm.
Yes,
Okay,
algorithm.
we'll put that algorithm up, and that algorithm is really complicated, isn't it? Huge. So we're going to pull that algorithm down, but that algorithm, Ray, goes through rate control and everything else, but you get to the bottom, and every patient with atrial fibrillation, regardless of whether you're worrying about the stroke, whether you're worrying about rate control, whether you're worrying about contractility, any of those things must be anticoagulated to prevent stroke. It's one of the diseases where everybody gets.
And that's where the Eliquis comes in.
Or Xarelto, or the other ones, or the rat poisoning.
Or the rat. No. I mean, well, that's what's in the question.
Correct. All right. So the first thing you got to look at is possible contraindications to anticoagulation. Well, if you look at
I'm trying to
this
say
list,
in my head, anticoagulation.
coagulation. But
Did I
anyway,
get
this
that?
You got it, just like they say it at Cornell.
Like it. I got it. Okay.
all right, this would the possible contraindication to anticoagulation is another big old long list. But when you look at it, there's hardly anything on here anybody ever had. Previous intracranial hemorrhage, real low platelet counts. I mean, that's not the average guy. Pull it down. That has atrial fibrillation. All right, so look at this one here very carefully. This is not a survival curve.
I was getting ready to say, that doesn't look like your weekly
Okay,
survival.
that's not a survival curve. This is the measure of clotting called an INR on Coumadin or rat poison with the complications of having a stroke, meaning you were under-anticoagulated, or pathological bleeding, meaning you were over-anticoagulated, and what the INR range is. Well, that INR is sort of narrow in there. And right smack in the middle of it, where you want to be, is 2.5, 2.6, 3, and when you get above 3.4, you're on that part, and when you get below 2 point something, you're on that part. And Ray, you can pull that down now. Ray, you manage Coumadin every day, don't you?
Yeah.
So it ain't easy.
No.
And if the guy ate a salad
moves to his spring diet, starts eating a lot of greens. You got to up his dose, and in the winter it goes the other direction, and or changes his diet in general, or the manufacturer of his pill gets changed on him. All those things.
Or he goes on a diet,
Yeah.
wants to lose weight, doesn't think about that. That'd be
Yeah.
caloric. Or he gets the flu or a common cold,
Yeah.
doesn't think about that. Or he starts getting his head congestion and starts an Eliquis or something. All of these medications can interfere with it. You got that one off, right? Go ahead.
Well, no, let me just say this, because I'm listening to you, and we're talking about anticoagulants. You're talking about Coumadin, you're talking about Eliquis, but let me just ask this. So what you're saying, a lot of medications we have on the medication, take with, don't take with,
Right.
take after this time, before this time. These particular medications, you have a balance that goes with it. You have a balance of a diet, you have a balance of, okay, you got to know whether you can eat greens at this time, this at this time. There's a lot more.
It's a tough medicine to manage.
There's a lot of
and
maintenance in this.
It has to be managed.
Managed, okay.
All right, now, I'm getting ready to show you something. When you get to these new drugs, which are direct anticoagulants, you can eat all the salads or the fewer salads you want. You can lose weight, you can get a cold, you just can't take aspirin unless it's prescribed in a small dose, and you can't take ibuprofen or any non-steroidal anti-inflammatory because you got a headache. You got to switch to Tylenol. But if you take these tiny little modifications, and those are easy, right? You just stop taking Advil or Motrin and take Tylenol. That's the end of that. Or you don't take a bunch of aspirin. Now, some of these people will be on one baby aspirin a day, but for a different purpose. But
Okay,
anyway.
well, wait a minute. No, wait a minute. All right, so let's go through there. My father was on Coumadin for a long time. Eliquis to me is a very commercialized drug. I don't know anything about it. I'm not on any of those, but it's the one I see now on TV. What is the difference? What went from Coumadin to Eliquis? How do you as doctors?
It's a whole different mechanism. It is as dangerous as Coumadin. You can bleed on Eliquis. You can bleed on Xarelto.
If you fall and hit your head or have trauma or something.
You can dig around in your nose and get a nosebleed.
Yeah.
I mean, you can. I mean, they're not without risk. They're just less risk than the Coumadin, and they're much easier to manage.
Now, introduction. See it in.
Yeah.
All right, pull the next one up. This takes clinical trials that compare the direct anticoagulants with rat poison, warfarin, Coumadin, and atrial fibrillation, and this represents like 90,000 patients. This isn't some group of 8, 90,000 patients, some who are on warfarin, some who are on the other Eliquis, for example. But if you go through here to what's called hazard ratio, meaning chances of bruising, bleeding, stroke, or everything else, and the average follow-up in these things is not a few weeks, it's 2 years and 5 years, in every single measurement, the effectiveness in preventing stroke is higher for the new classification of drugs, and the complications of bleeding are lower. Pull that down, Lonnie. Now, Ray is in the research business, and I have said we're in the cancer research business. Ray's in the diabetes and anti-inflammatory and antibiotic research business. But what I've said is that quality research, when they have a protocol they ask you to follow for breast cancer or for diabetes, they can't get that through the tumor board unless that experimental treatment is thought to be equal to
Or superior.
at the worst, or superior,
Right.
or secondly, equal to with fewer side effects and complications. So none of these things that you're asked to do you have to worry that the effectiveness is going to be less. It's either going to be the same and less toxic, or it's going to be the same or better depending on what the outcome is.
So we use the word standard of care. So the experimental drug has to be superior in effect to the standard of care or more safe, or both.
You brought up something a minute ago. You said it has to be managed. And I watched my dad, and I mean, the simplest cut. I mean, just what you would normally maybe get in a garden or anything.
A little harder to stop.
Yes, a little
But
harder.
not terribly hard to
Okay,
stop.
well, what's in, and this is my, I don't know, what's in aspirin? Because I'm a daily aspirin. Now, I am with the daily aspirin. It's not bad, but somebody will say, "Are you bleeding?" Yeah. Nowadays, it takes me.
Okay, this is easy. You've got two parts of the clotting mechanism. When you draw a tube of blood, you got plasma that you can see. That's the liquid part. All of the stuff we're talking about with Eliquis and Coumadin is to interfere with the clotting in the liquid part. When you have a cut and you breach that integrity, or when you are going to have a heart attack, it's not the liquid part that starts it, it's the cellular part called the platelet. So platelets aggregate immediately upon trauma, and aspirin stops platelets from aggregating, doesn't stop them, it diminishes them so that they don't pathologically aggregate in your coronary artery or your carotid artery and kill you. So I did say some of these patients would be on Eliquis and a baby aspirin. That's going to be the guy that this is not, who does have coronary disease, has had a stent perhaps, or has had a carotid, or has peripheral vascular disease. He would be on Eliquis for atrial fibrillation to prevent the liquid part of blood from clotting, and a baby aspirin to stop the platelets from clotting, starting a process of clot in another place like an artery. So they're totally different. Now, what you notice out here when you cut yourself is the same, because when you cut yourself, the platelets have to start the aggregation, and the guy on Eliquis, his platelets working just great. It starts that, but the soup part or the plasma part doesn't clot quite as quickly. So the treatment's exactly the same, whether you got the aspirin or you got the Eliquis. When you cut yourself with a thorn out there, you pull out your handkerchief or a Kleenex or a piece of toilet paper and you push down on it in a minute or two, put a little pressure on it and let it dry and stop and go back out there and go back to weeding your garden. It's when you fall and hit your head against the edge of your sink, or you have a car wreck, or you don't
know internally how bad you're bruised? Is that a problem?
Well, no, not really. It's a problem if you whack your head or you're in a big trauma. You can have pathological bleeding internally or externally.
Okay. So we're talking about atrial fib here, but basically these medicines are used in any what we call hypercoagulable state, which can be COVID vaccines, certain cancers. Some patients present to the doctor with a DVT, a big clot in their leg, for no good reason, and a good primary care physician will say, well, we need to figure out why that happened, because you were not bound up, you were not sitting on an airplane for hours, there's no reason for you to have this blood clot, and you go looking around and you find out they've got cancer. So hypercoagulable states where your blood wants to clot inappropriately, as in atrial fib, have to be treated with these drugs. These drugs, as Bill referred to in the research, are safer and more effective. But they do wedge you to your doctor. You have to be managed, attention has to be paid, and you have to know what to do when you do bleed.
And more importantly, for this guy, it frees up his travel. Yeah. He doesn't have to get his finger stuck every 3 or 4 weeks, and he can eat salads. Yeah. And it is slightly more safe, slightly less toxic, much easier to take, and the issue is expense, and you don't have the expense because you've got some kind of insurance that pays for it. So what was my recommendation was follow your PCP's advice, which was don't take the Coumadin anymore, switch to this if you can afford it. And that was basically what the question was. Right?
We're good?
We're good.
We're good. Thank you, Georgia Cancer Specialist affiliated with Northside Hospital Cancer Center, for our segment. It's now time for question 2.
Now, this question, I saw this question, I thought to myself, I know where this question came from. I'm pretty sure this person here watches, because what they're telling us is you remember here a couple weeks ago we were talking about Merkel cell cancer, and you gave an immunotherapy. With that question followed about 6 weeks after a guy who had a big squamous cell recurrent cancer that was all wrapped around his carotid arteries. It was in his neck, as I recall. And we treated him with the immunotherapy again, and we sat here and we talked about the Jimmy Carter drug and about Keytruda. Keytruda, you're used to Keytruda, right? Well, this question is about a similar thing where the recommendation is not Keytruda. Lord, how can you possibly have a question that doesn't have Keytruda as the answer?
Usually, that's right.
Huh? What do you think? You think that's possible? All right, where'd my questions go? Did I drop them? Oh, there it is. You ready? Right. My father is a very, very healthy and 80 years of age. BKP asked when we started this, how do they know that? Well, I'm 82 years of age, and I consider myself very healthy.
I'm not
with
saying a
atrial
person's
fib-
not, but
right.
when the question starts out, I'm a very healthy 70, a very healthy 75.
80.
I'm not, and 80. I'm not questioning that. But we just left a question where you said AFib could be totally unknown.
Yeah.
Right?
Frequently, yes.
So that person could write this question and say, I'm a very healthy.
He absolutely could. Yes,
right?
yes,
so
he
that's
could.
that's where I'm going with that.
We can say Bill is very healthy, but he is old as dirt.
Yes,
Yeah,
old as
yeah,
dirt. All right.
yeah.
All right, now listen.
Methuselah,
Ray and
go right ahead.
Ray and I both meet the criteria for most of this question. He had a skin cancer on the top of his head 3 years ago, had removed, no problem since. Well, I had 7 biopsies last year and 4 were cancerous. And one of them was on my head.
That.
All right. He had a squamous cell cancer removed from his right ear 1.5 years ago, and also has had no problems, but there are no records. So that must mean that was done somewhere when he was traveling someplace. 4 months ago, a large knot appeared in front of his ear, and a cancer head neck, ENT, and plastic surgeon removed large masses from his parotid gland. His parotid gland is this gland that swells up when you get the mumps. Nobody gets the bumps anymore because we've eliminated it, but us old people remember the mumps. Parotid gland makes saliva, so there shouldn't be any squamous cell cancer in a parotid gland. If it's going to have its own cancer, it's going to be a glandular type of cancer. That were cancer, they removed all of his neck nodes. So that means they did a neck dissection down here. Several of them had cancer in it. So here this guy had a cancer up here in his ear that a year and a half later has a big mass in his neck, his parotid gland, and at surgery, head and neck cancer surgeon and plastic surgeon, they went down in here and he had lymph nodes. Why was there a plastic surgeon there? Because when they took out that parotid, they have to take out a whole huge hunk of skin there. So that plastic surgeon had to take a flap of skin from the opposite side of his neck, roll it around here, and sew it up there. And that's why it was not only just a cancer operation, but a reconstruction operation at the same time. Several of them had cancer in them. They now recommend radiation, even though they say we got it all. How many times have we talked here about breast cancer or something else? The surgeon's over, they go back and say, you need some radiation. And people never do quite get the answer why I want to have radiation if they got it all. So anyway, here they go. They say the tumor board made that recommendation. So that tells me another thing. He's in a really upscale place where they got radiation therapists, medical oncologists, and surgeons that went over this case and made the decision that his best interest in terms of recurrence include radiation. We're going to show that in just a minute. The tumor board made that recommendation. What are your thoughts on what we should do? Well, first of all, I'd follow the tumor board. But there's another part of this question. He was operated on 120 miles from home at a cancer center. But there is a radiation therapy center 15 miles from where Dad lives. Now that could be local right here, right? because if he was operated on down at Northside or Emory, it'd be 125 miles from many of the places up here, and we do have radiation in Blairsville, Georgia. So I don't know whether it's for here or not, but at least that fits our local place. All right, just get the next one up. This is going to be relatively quick because this is kind of simple. You got that big old ugly one up there? So we're talking about squamous cell cancer. This one happens to be on the lip. Pull that one down. And the issue that you're really talking about here is recognition and management of, this got to be high risk, right? High risk, aggressive, cutaneous squamous cell carcinoma. Because Ray and I have had a dozen of these things, and we didn't have to have any radiation, and went back and got it cut out and go in every 3 months, and it didn't come back. So what's the difference between, pull that down now, Lonnie. What's the difference between ours, that has been simple, and high risk? So there is a difference in risk for just old sun-related skin cancer.
And you're talking about self-neglect here?
No, I'm talking about, this really wouldn't have been self-neglect. I think this would, you mean us being neglecting ourselves?
No, I'm talking about the patient
No.
seeing or leaving something there too long without
No,
getting it attention.
it was removed a year and a half
Okay.
before,
All right.
so it had some risk to it, and he'd had a previous one, so I got the sense he's going to
He's paying attention now.
regularly. Yeah. Okay. Well, Lonnie didn't have this one, so I'm gonna pull it up here. But the rate of recurrence of these skin cancers is much higher when the location is the lip or the ear than it is on the face, the hands. You pull that down. Oh, it's not up, but you don't have that one. All right. The reason that I think that's important is the lip is not normal skin, is it? It's thinner, and my nose and my scalp and my cheeks get the same amount of sun as my lip. And the skin of the ear, particularly inside the canal, which is, I get the idea of where this one was, is a little bit different than the skin on the tip of your ear or your forehead or your chin. So those two places, even though they're in the same ballpark as everything else, when you get a cancer in them, a skin cancer in them, they can recur at a much higher frequency than a half an inch or an inch away. So that was an important thing. All right, put the next one up. You see this big one here of this woman's face?
Yes.
You see how it's going right up next to the nose?
Yes.
That was the third place on the list where recurrences are higher, you pull that down, than in the same neighborhood. And as you know, the skin that's in this little groove right there and right up in there is different than the skin on your forehead and the same neighborhood. Right, Lonnie? Is that skin different? All right. So interestingly enough, we're going to get through this quick. This says Brigham and Women's staging system for cutaneous squamous cell cancer. And there are then a variety of high-risk factors, which we're going to look at in just a second in what's this next one going to be? Pull that one down, put the next one up. What's this going to be right here?
An algorithm.
That's your algorithm.
Yes.
We don't have a survival curve
Right.
today for skin cancer, okay? So what this tells you to do, now what you're doing, my question,
It
Jim?
almost fell off.
All right, so when you start at the top up here, these are patients who got squamous cell skin cancer. And Ray and I have both had Mohs surgery. So you got Mohs surgery over here. Lonnie, you can pull that down. I don't want to confuse everybody, but once you start working your way through this Mohs surgery, what's the edge look like, and looking at it under the microscope, there are features that are the same kind of features you would see when we talk about breast cancer or melanoma. Does it invade the lymphatic? Does it invade the blood vessel? Particularly now, remember he had 2 lymph nodes down here in his neck. So you take those risk factors, go back to that previous Brigham and Women's risk assessment, and the presence of these 2 little lymph nodes, this recurrence 18 months later tells us it was in the blood vessels go into the skin. Then that algorithm says radiation therapy. We still, here's our, right there, that's our Keytruda right here. Keytruda's downstream from this. So the original thing this patient should get, just like the patient you're trying to conserve the breast, is radiation therapy. Don't give them any kind of Keytruda or anything else unless they recur. And it's very nice to know that they've got something you can do. So my recommendation is get the radiation therapy. Now the second part of the question was, do you drive 125 miles to the university for the radiation therapy for a skin malignancy in the head and neck? And the answer to that question is no. I believe that your community radiation therapist anywhere in the country, his equipment has to meet a standard to have his licensure. He has to be accepted in the community by his surgeons and his gastroenterologists that are sending him patients. And this is really easy. I mean, this is such easy radiation that it doesn't require some. Now, if you're talking about stereotactic brain radiotherapy for metastasis or something that's really complicated, it might be worthwhile driving to the university. But this is something that your average radiation therapist in your community could do. So I'm going to say follow the tumor board's advice, but get the tumor board's advice and all your records and get your dad over to your local
The
guy.
local radiation therapist is going to know the scope of what they can do and what their machine can do. And if they say they can do it, they can do it.
They can, and you got to trust them.
So let's go back over. We talked about this last week about self-screening for skin cancer, because
We did, didn't we?
between last week and this week, I had a patient, and he's not my patient. I had a person in front of me. I volunteered, worked at the polls Tuesday, and was face-to-face with a lot of people, many of whom I didn't know. And a fellow was sitting there looking at me, and he had a big old thing on his.
Examining while you're supposed to.
Well, it's part of my life hazard. Anyway, I said to him, I said, "Who is taking care of that?" And he said, "I am." And I said, "Would you please go see your doctor and have him look at that?" He knew exactly what I was talking about. Okay, I mean, he had a obvious
Thing.
big old skin cancer above his eyebrow, which he was putting lotion on. But that's obvious, and sometimes us guys are just, we think we're a
Men.
car and we don't need a checkup. So back to, how do you check for skin cancer? You know, we talked about lesions that change in size, color, contour, surface.
Right.
Okay, easy to remember stuff. But also there are early lesions that when you know, for those that take a bath at least once a week, like I know you do,
Saturday night
bath, when you touch your skin, if there's this consistent rough area, okay, particularly in the high sun exposed areas, tops of our ears, bridge of our nose, Bill talked about top of our eyebrows, those areas
Bald
that
head.
top of your head, you know, like this one right here, it's a little bit rough. I feel it every time I wash. Well, that needs to be seen. I need to go get the doctor to look at it, and he's going to spot weld it and get it off of me. But you can feel things very, very early, and that's worth paying attention to. That's my point.
Now, do you remember here about a year ago, last year before the Stanley Cup, so it was a year ago, where that woman took the program and wrote on the program, "You've got a thing on the back of your neck, you need to see a doctor," and kept banging on the glass
I think I remember that. Yes.
to the stick boy.
Yeah.
So the stick boy
I do
had a
remember that.
lesion on his neck that the nurse, it was a nurse that was sitting right behind the glass, saw, and she just couldn't get out. That guy went and had a melanoma removed from his neck that was found by the nurse watching the hockey game. So yes, you are examining, if you're in the business, all the time. I mean,
Yeah.
you know,
I mean, I don't know what's going on with me, but last month on vacation, I was in a store, and the young guy attending me, I mean, he had to be in his 30s at most, had an obvious melanoma on his neck. And I said to him, has anyone seen that? He's like, no. I said, do you have health care? He said, yes. I said, would you go see someone about
now,
that?
you know he had health care if he was in Switzerland now.
Yeah, he was
right?
in Switzerland.
You didn't need to ask him that question.
Right.
He had health
So
care.
I remember last week you wanted to use the beach as an opportunity to do something.
Yeah, I think that's, I think I'm going to patent that. I think we don't need lifeguards, we need skin checks. okay? And somebody spotting sharks, okay? We can do the shark spotting, yeah.
Skin.
Yeah. And let the other people drown. Okay, there's not many of those.
Woo.
Wait a
All
minute.
right. Now, BKP.
Just every once in a while.
BKP has insisted that I not show the big thing in the news, but the big thing in the news, interestingly enough, in the first 8 things in the news, there is not one COVID article.
Yeah, we have a new fear porn. We have a new fear porn coming out. But anyway, what you
Well,
got there?
okay, I'm not going
What
to.
did you say?
Fear porn.
Fear point.
Porn.
I know we said I was trying to clean it up.
You're cleaning up a little bit.
All right.
so.
Ping pong here.
Ping pong.
I want to know what that is.
Well, that's the news media for the last 2 years running around. What do we need to be scared to death of? And we've had COVID. Okay.
Yeah,
Now
it was Zika. Remember when we were doing the
Yeah, we had
Zika
Zika,
updates?
COVID. We always got something to be scared to
Okay,
death
so
of.
what I was saying is, I have heard more people ask me about monkeypox. Last week, there had been no cases of monkeypox in the U.S.
No identified cases.
Excuse me, yes. There are 9 cases of monkeypox in the U.S. as of yesterday afternoon, and they are in 7 different states. Now, I don't know whether all those guys were at those 2 parties in Davos, Switzerland or not, where they were rubbing their bodies on each other. But you do not have to worry about monkeypox. I sent Ray, Emory put out a newsletter to all of their staff about how to handle monkeypox, because it's going to end up in the ER, or it's going to be referred to the Emory, and they have all of their institutions are in this area where the high-risk population lives, and that disease is, unfortunately, does not have any real antiviral therapy. This is now, Lonnie, were you immunized? How old are you? You were not immunized against smallpox, were you, where you got that thing? So, were you?
Yes.
Okay, well, Ray and I were immunized against smallpox. I think people that are about 35.
Is that the one
40
where they lined us up on the wall?
Well, yes, or
Shot
back
us
in
in the
my day, they took a pin and pricked you. That was 1942.
You had a little mark.
Oh, I
Yeah.
have a mark.
Yeah, it makes
Okay,
a mark.
well, you
It would make
you
a
had the
mark even
smallpox,
with, it would make
yeah.
a mark with a gun. Well, so anyway, smallpox vaccination prevents you from getting monkeypox. But that smallpox was eradicated from the world about 35 years ago.
And they stopped doing the
immunizing
vaccination.
them.
Yeah.
So this young population who are, I would say, sexually aggressive and not terribly prudent are at risk for that disease. And that's all I'm going to say about that.
I have a cool story about my medical education along this line. I had a pathologist professor, old fellow, been around forever, and at the end of every lecture, he would say, "Do not touch the lesion till you know what it is." And his emphasis was because he'd had some peers or friends over the years who barehanded touched things, got the disease, and died from it. But every medical student that sat in his lectures had that drilled in their head: do not touch the lesion till you know what it is. So I'm out on my first junior medical student rotation doing my first physical exam in the hospital, and there's a lady that is admitted with a diffuse rash. And it's a really interesting looking rash, and it's red and spotty, and it's all over her body, and I'm sitting there talking to her, and without that voice going through my head, I'm doing this.
Well, that's the day before gloves.
Before gloves. There were
There's
no
no
gloves
gloves.
around before at this time, okay? And then suddenly his voice went through my head. It said, "Do not touch the lesion till you know what it is." So I got up, went out to her chart, and looked up what she was in there for.
Syphilis.
Disseminated gonococcus.
Oh,
So I did some real serious hand scrubbing right there,
Yeah,
and I never made that mistake again.
anyway. All right, did you like that one?
Yeah, so smallpox, no monkeypox.
No monkeypox.
Yeah, don't worry about the monkeypox. Don't
You know, I'm
be
not-
rubbing on things that look ugly.
I'm not going to tell you what year. I'm not going to tell you what year, but we're going into kindergarten, and they lined us up on the cafegimatorium. See, we didn't have all this big money, so we had a cafeteria,
Yeah.
a gym, and an auditorium. Okay?
All in one,
So we
yeah.
had the cafegimatorium.
Yeah.
So they lined us kids up going into kindergarten along the wall, And I remember the nurse at the end and somebody checking it off, and it was like some little gun.
It was a
You
gun.
You went there and
And
now,
you realize then they didn't wipe the gun off.
Now
you have to wipe the gun off.
I have the mark.
The mark of the beast.
The
Anyway.
mark of the vaccine.
But I got to tell you something.
Yeah.
I vaccinated my brother.
Oh, because you got up next to him. Yeah, that's true.
When I was 5, he's 3. We slept in the big twin bed, and they didn't say anything about separating us. And his face slept on my arm that night. And I have the mark here, and my brother has the mark.
Yeah,
here.
that's fair. That was a very common thing in those days.
Was it?
Yeah.
Okay.
All
End
right.
of story.
All right,
There
now
you go. You got anything?
You got your expert panel coming in over here. All right. So what's that percentage?
12.1.
What was it last week?
I don't know.
12.1. What was the week before that? 12.1. You know why?
Why?
Because they quit taking the data. They're just letting that one drag out there. They're not reporting those things now, but once every 2 or 3 weeks. Now, how many cases have we had? How many new cases we had in Fannin County in the last week?
I don't know.
One.
One.
So
Okay.
we were 3 weeks without a case. Now, is that a real case, or is that if they added up that 0.6, 0.2, it actually is a case? I know who it was. It's one of our patients.
Nobody
And-
died.
And it's still no deaths, still back to 161. So the takeaway message is there's a new variant now. That's called the Omicron BA6194-5 or something or other that was due from last week. And there's going to be a new one next week. I don't know what they're going to call it. But my idea to you is go out there and live your life. Now, as you know, I'm going to be out of town 2 Fridays in a row in a few weeks. And I got a note from Italy today. I got to have a test 72 hours before I enter Italy, and I got to have proof of vaccination, and they will not accept antibodies from persons who have had COVID as a
Which is
criteria to
the
enter
superior
Just trying to tell
immunization.
you
No,
what-
I
what
just
the
got
rule-
back from Europe.
what the
So
rules
there's
say.
a traveling kit made by Abbott. Buy one for you and your cadre on the way in and on the way out,
Yeah, I'm gonna
and
go
you
over here
do
and-
it at home.
I can go over here and get it from the
Yeah, you can order them online, buy a dozen at a time, Bill. For your, what do you got? 4 or 5 people going with you?
I got 21 going with me.
Yeah, so you need a whole box of these. Hey, listen, I got an observation here. I can't believe I haven't noticed this before, but I got to tell you something. Your phones are mating.
Oh, gosh. Okay, do you have a joke?
I got to say,
That's it right
donate
there.
blood. It's really
That's-
important.
Donate.
Donate blood.
Like, because if you don't have a joke, one of our viewers sent a joke for you.
Okay, I want to hear it.
Your joke for Ray. This
Okay.
is what it says. Your joke for Ray. What do you get when you cross an owl with a goat? It's a hootenanny.
That's a Southern joke.
Yeah, it's a
All right.
hootenanny. Okay.
Screwdriver walks in a bar.
Yeah.
Bartender says, "We have a drink named after you." He says, "You got a drink named Philip?"
All right, Lonnie,
All
we're
right,
gone.
we're going to take a break. The All-Star Political Panel is up right after this, and obviously there's a lot to discuss as always. You guys have a safe trip to Ithaca. I know you're going. Your grandson is your
That's
grandson.
right, grandson.
Going up there. Graduation this weekend. We'll see you back next Friday. Okay, that's a snazzy jacket. I like that jacket.
His wife bought it for him.
Huh?
His wife buys everything for him.
I know
She does. She says I clean up pretty good.
you do.
Hey, listen,
Shirts.
Bill,
We know where the shirt.
You
It's-
may
this
do
is not
better
you.
to
The shirts,
have an
the-
Uber drive you up to Ithaca than wait on the airlines right now.
Right.
Yes. Airline's still trying to figure out how you get him to Ithaca via Syracuse. Safe trip. All-Star Panel right after this.